You know, usually when we jump into a deep dive about a medical procedure, there's this expectation of, like, total precision.
Right, like an engineering manual or something.
Exactly.
Yeah,
Like you break an arm, the x-ray shows the jagged line, the doctor sets it, and boom, it's fixed. We really like things to be, immediately visible and categorized.
Yeah, X leads directly to Y.
But the second you step away from setting broken bones and step into, well, regenerative medicine and aesthetic surgery, the x-ray machine is essentially broken. We end up in this really murky landscape.
Oh, it is the definition of biological muddy waters. Healing, especially soft tissue integration, it's never a linear binary process of broken versus fixed.
Yeah.
It's this constant evolving adaptation.
And that biological reality is right at the absolute center of today's deep dive, because you, the listener, sent over this incredibly specific question based on some intense research you've been doing.
It's a great question, too.
It really is. You asked, will I see the results of the labial puff immediately? And to answer that, we are looking at this massive stack of sources you provided.
Which is quite the stack, by the way.
Oh, it's wild. You got these glossy, super optimistic clinic brochures promising instant transformations,
Yeah.
right alongside incredibly sober, hard clinical data from nice medical reports and day surgery directories.
Yeah, the contrast is jarring because the word immediately is, it's doing a tremendous amount of heavy lifting in those cosmetic brochures.
Right. So what's the actual mission here?
Well, the short answer to your question is yes, you will walk out looking different than when you walked in. But the reality of what immediate actually means, like cellularly, is a completely different story depending on the method.
Because what you see in the mirror at hour 1 is like almost never the final architecture of the tissue at month 3.
Exactly.
So to really grasp that timeline, we have to understand what is physically happening to the tissue to even prompt this procedure in the first place.
Right, the underlying biology.
Yeah, so the labial puff or labia majora augmentation focuses on the outer lips of the vulva. And the clinical literature points out that this area just naturally loses volume, elasticity, and fat over time.
It's a completely universal progression.
I kept picturing it like a biological cushion. Like these tissues act as a natural shock absorber for the more sensitive mucosal tissues underneath.
That's a really good way to visualize it.
Right. But over time, because of biology and gravity, that cushion just naturally loses its padding. The stuffing flattens out and the skin begins to sag.
Yeah, and it's driven largely by hormones. The labia majora are basically just adipose tissue, which is fat and skin. As a woman ages, or specifically goes through menopause, there's this dramatic drop in systemic estrogen.
And estrogen is kind of the glue, right?
It is. It's the key driver for maintaining collagen and elastin in the skin. It also dictates where fat is distributed. So with age, menopause, or, significant weight loss or childbirth, that structural support network simply degrades.
And when that cushion deflates, it's not just a visual thing. Functionally, it leads to severe chafing, irritation, vaginal dryness, or even outright pain during exercise, like cycling.
Or intercourse, yeah.
Aesthetically, it causes self-consciousness in tight clothing, which the brochures bluntly refer to as the camel toe effect.
They don't mince words.
No, they do not. But reading through the historical context in your research, specifically this piece from Aesthetic Medicine, you realize that the conversation around this discomfort carries a massive amount of historical baggage.
Oh, the history is incredibly dark.
Yeah, this isn't just about deflated tissue. This is a part of the body that has been deeply, deeply stigmatized.
Right. Back in the 1860s, you had prominent physicians like Isaac Baker Brown treating female hysteria, which, is basically a catch-all diagnosis for any woman displaying anxiety or just noncompliance.
Just breathing while female, basically?
Pretty much. And they treated it by performing forced genital surgery. They were literally removing the clitoris and altering anatomy to cure psychological conditions.
That is just horrifying.
It really is. Female genitalia were just completely shrouded in secrecy and intense medical control.
Which makes the modern context you sent us so interesting. Because the wellness and aesthetic literature frame these modern procedures as like female empowerment.
Right, a total flip.
Yeah, it's pitched as women reclaiming their bodies and refusing to just silently endure chafing or dryness that, their grandmothers were told to just live with.
But then you look at the national health guidelines in the stack.
Wait, exactly. Because the NHS sources explicitly state that noticeable skin folds, variations in size, drooping, they say it's 100% normal, it's standard biological variation.
Yeah.
So are these clinics just pathologizing normal aging?
It's a great question, and it represents a massive philosophical divide in modern medicine.
How so?
Well, the public health perspective is rooted strictly in anatomy and vital function. From their standpoint, age-related volume loss is just as normal as getting wrinkles on your forehead.
Right.
They generally only intervene surgically for profound traumas, like severe tearing during childbirth or conditions like labial fusion where the tissues actually adhere together.
Oh, wow. And that requires surgical separation and what, like heavy emollients just to heal?
Yeah, intense post-op protocols with things like Vaseline just to function normally again. So they are treating severe medical necessity.
Whereas the private sector is treating quality of life.
Precisely. The private clinics argue that while the anatomy itself might not be diseased, the functional discomfort is real.
The chafing and the pain.
Yeah. If a patient cannot ride a bike without pain or suffers from chronic severe dryness, the modern approach is about giving that patient control over their comfort.
It's moving away from forcing women to adhere to a single standard of, like, a normal aging body.
Exactly. It's asking, can we safely intervene to improve their daily physical experience?
Okay, so if the cushion is deflated and causing pain, the clinical focus becomes how to safely restuff it. Which brings us right back to your core question about immediate results.
The method.
Yeah, and the fastest, least invasive way to restuff that tissue, according to the sources, is through hyaluronic acid, or HA fillers. Products like Deserial, Deserial Plus, or Juvederm.
The temporary route.
Right. The brochures promise a 15 to 30-minute procedure. Numbing cream, inject the filler, and you walk out with immediate volume. But the biological data explains that the volume you see on day 1 is fundamentally different from the volume on day 4.
Very different, because to understand it, you have to look at the mechanics of hyaluronic acid.
Okay, let's unpack this. HA acts like a sponge, right?
Yes, but initially it's just a gel. HA is naturally occurring in the body, but in injectables, it's cross-linked into a thick gel. When injected, that immediate volume you see in the mirror at hour 1, it's purely mechanical.
So it's quite literally just a physical blob of synthetic material stretching the deflated skin back out.
Exactly. That is the immediate result. But that gel is intensely hydrophilic. It acts like a biological sponge. Over the next 48 to 72 hours, that hyaluronic acid begins to chemically attract and bind to water molecules from the surrounding tissues.
So wait, does that mean the volume I see immediately after walking out of the clinic is mostly just the dry sponge? And the real hydration result actually peaks a few days later?
That's exactly it. What's fascinating here is that the true result is a combination of that initial mechanical displacement plus deep biochemical hydration.
Which is why they mix it with antioxidants.
Yes. Products use antioxidants like mannitol to protect the HA from being broken down too quickly by the body's natural enzymes. It prolongs the effect. And this dual action doesn't just plump the skin, it actually improves tissue regeneration and reduces that friction pain.
But because we are dealing with a sponge that is actively sucking up water, the aftercare protocols, which the sources say are basically identical to facial filler protocols, make a lot of sense.
You have to be so careful.
Yeah. The injection causes microtrauma, and the body's natural response to trauma is to flood the area with fluid. If a patient does anything to increase blood flow in those first 48 hours, they're going to flood the sponge.
Which means no alcohol, no blood-thinning meds, and definitely no extreme systemic heat like a sauna or a hot bath.
Because that dilates the blood vessels.
Right. That pushes massive amounts of fluid into an area where a hydrophilic gel is already actively pulling in water. You turn a carefully calibrated hydration process into severe distorting swelling.
So the immediate result requires intense behavioral management. And even if you manage it perfectly, the body eventually metabolizes the gel. The consensus is HA fillers last roughly 9 to 12 months.
Sometimes up to 18, but yeah, it fades.
It's an immediate result, but an entirely temporary one, which naturally pushes patients who want a permanent fix toward the second option in the data, autologous fat transfer.
Right. And when we move from injecting a synthetic gel to transplanting living human tissue, the biological complexity just skyrockets.
Because a fat transfer involves liposuction, right? Harvesting fat from the abdomen or thighs, purifying it, and injecting those living cells into the labia majora.
Yes. And looking at the timelines, surgeons also claim the results here are immediate. You will absolutely see a massive increase in volume right after surgery.
But, and this is wild, surgeons purposefully overcorrect the area. Like Paul Banwell and others, They inject far more fat than the patient actually wants.
They have to. They overcorrect because of the biological reality of transplantation. When you extract fat cells from the abdomen, they are entirely disconnected from their blood supply.
They're starving.
Exactly. They are living tissue deprived of oxygen and nutrients. When injected, until they can establish a brand new vascular network, until microscopic capillaries actually grow into them, many of them will simply die.
It's like packing for a trip knowing the airline is guaranteed to lose a third of your luggage, so you deliberately overpack.
That is the perfect analogy. The body is a strict toll collector. It will naturally reabsorb and metabolize the cells that fail to revascularize.
And the clinical estimates say, what, a 30 to 50% loss over the first 2 to 3 months?
Yes.
So if I look in the mirror immediately after a fat transfer, I'm actually looking at an exaggerated, overpuffed version of myself.
You are. The immediate result is functionally a false positive. It's a huge psychological challenge for patients. You're seeing 100% of the injected fat plus surgical swelling, knowing half of it is going to slowly vanish over 90 days.
That is such a mind bender. And the nice waste medical data you pointed out proves this is just a universal biological reality, right? Not just a quirk of genital surgery.
Oh, absolutely. Look at the NICE-WEAS guidelines for breast reconstruction using lipomodeling. It's just fat transfer on a larger scale.
Right.
The clinical data documents that 30 to 40% of the fat volume is reliably lost before the tissue stabilizes at 3 to 4 months.
Wow. And the data on HIV-related facial lipotrophy show the exact same thing.
Yes. Patients who lost facial fat due to early HIV meds were treated with fat transfers or synthetic polymers like Sculptra or Aquamid.
And their tissues absorbed so much of the transplanted fat that they routinely required multiple top-up surgeries just to achieve a permanent cheek thickness.
Exactly. Whether reconstructing a breast, restoring facial volume, or augmenting the labia majora, transplanted tissue behaves identically.
The environment dictates survival.
Yes. The true permanent result of a fat transfer is completely invisible on day one. It only reveals itself months later.
Okay, so whether a patient chooses the temporary hydration of a filler or the complex transplantation of fat, immediate results also carries the heavy burden of immediate physical recovery.
Definitely.
Because the Bandy-S directory classifies these as day case procedures. You go home the same day. But walking out the door doesn't mean your body isn't in a state of alarm.
The immediate post-operative reality is significant swelling, tenderness, and bruising.
And here's where it gets really interesting. The bruising can be surprisingly extensive, and it has to do with gravity, right? The research on inguinal hernia repairs highlights this perfectly.
Yes, gravitational fluid dynamics play a massive role. The hernia data notes that after a groin operation, bruising and fluid travel straight down into the labia.
Because of interconnected pelvic tissues.
Right. So if a patient has liposuction on their abdomen to harvest fat, the inflammatory fluid and blood from that trauma is going to be pulled downward by gravity into the exact area that was just injected.
So the swelling and deep purple bruising can look incredibly dramatic.
Extremely alarming if you aren't prepared for the physics of it.
Which begs the question, if I'm a patient sitting at home on day 2, how on earth do I distinguish between normal, I just had a needle in a sensitive area swelling, and a call the doctor immediately, complication?
It's vital to know the boundaries between physiological healing and pathological signs. Normal healing is a trajectory of gradual improvement.
So it should be getting better every day.
Right. The swelling might be dramatic, but the pain should be entirely manageable with standard pain meds, and it should steadily decrease.
Whereas a complication breaks that trajectory. The guidelines from cosmetic surgery solicitors and Baypress outline very specific red flags.
Spreading redness that feels hot to the touch, sharp pain that suddenly worsens, or unusual discharge.
Or a seroma, right? A pocket of fluid.
Yes, a localized, concentrated pocket of fluid under the skin that feels like a hard lump. Those require immediate medical intervention, not just ice packs.
And the required rest is no joke either. Downtime means no rigorous exercise, no heavy lifting, no intercourse for anywhere from 1 week for fillers for 4 to 6 weeks for a surgical fat transfer.
Because surgical healing is a very slow, measurable process.
Like that ESGE Congress data on uterine niche depths.
Exactly. Doctors use ultrasound to monitor the slow reduction of internal surgical defects over months. The external skin might look healed, but the tissues underneath take months to fully mature and settle.
So, circling all the way back to your core question, will you see the results of the labial puff immediately? The answer is a heavily qualified yes. You will absolutely see a physical change in the mirror the second the procedure is over.
But immediate does not mean final.
Right. With HA fillers, you are waiting a few days for the final hydration to peak. And with fat transfer, you are looking at a deliberate overcorrection that will shrink by up to 50% over a few months.
The initial visual is quite literally just the starting line of a complex biological adaptation.
Which leaves us with this thought that really lingered after reading through all this material.
Mm.
We spend so much time talking about achieving a final result,
Mm.
but our bodies are in a constant state of flux.
They never stop changing.
Gravity never stops pulling. Menopause and hormonal shifts inevitably alter our tissue. The aging process doesn't pause just because a surgeon intervened.
It creates a fascinating philosophical paradox because if a fat transfer is successful, those surviving cells are technically permanent,
Right.
but the overall environment they live in, the skin elasticity, the hormonal support is entirely transient.
So is any aesthetic procedure truly permanent? Or are we simply resetting a biological clock that immediately starts ticking again the second we walk out of the clinic?
It's a great point. If our baseline is always shifting, how does that change our definition of what is normal?
It definitely changes how you look at what we expect from medicine. Thank you so much for sending in such a fascinating, diverse stack of sources. It pushed way past the marketing gloss and forced us to look at the messy reality of human biology. Next time you look at a simple broken bone on an X-ray, just appreciate how wonderfully straightforward it is. Keep those incredible questions coming, and we'll catch you on the next deep dive.